Hello and welcome to our July 2022 review of the recent literature in lupus. I'm Ed Vitale, I'm the chair of the Lupus Forum and a rheumatologist and clinical academic in the University of Leeds. And for this month's podcast, I'm joined by my friend, Professor Eric Morand at Monash University. Hi, Eric.
Ed, it's a pleasure to join you. I wish we could be together in person to do it, but this will do. It's great to do.
It's becoming more normal, isn't it? So what time is it for you over there now? Evening?
It's 5:20 p.m., almost gin and tonic time.
Yeah, we're having meetings about like this sorts of times all the time. It's either early morning for me or late night for you. Yep. every time. So we've done, as usual, we've done our review of the highlights from the past couple of months from the literature that the steering committee have selected out a few papers that we're going to go through together. And the first one is one on anifrolumab, so a subject that I know has been very close to your heart. You've been leading on that program a lot, and this is one of the several sub-analyses that's been done about an indirect comparison between anifrolumab and belimumab.
Yeah, thanks, Ed. So yeah, it's a pleasure to talk about this paper. So just by way of disclosure, I was the PI of the TULIP-2 phase 3 trial of anifrolumab, and I have been a paid consultant for AstraZeneca. So that's my disclosure in relation to this work. So I'll start with a kind of disclaimer, I guess, which is that you're not supposed to compare studies. This is a paper comparing studies. So what does that mean for our audience? Well, many differences between the way that trials are recruited to and executed and interpreted that in general terms, it's very challenging and probably not ideal to compare the results of drug A in trial A and drug B in trial B, because it's not the same as a head-to-head study, which is the gold standard for proving non-inferiority or superiority. And we're reminded of the non-inferiority studies of TNF versus another TNF, of things like tocilizumab versus TNF, and so on. So those studies would be very expensive and take years to do. So what's a shortcut? The shortcut is to do the best job you can of looking at data that's available to answer the questions that you have. So here, Ian Bruce has published a paper in the Journal of Comparative Effectiveness Research, comparing the efficacy data published for anifrolumab with the efficacy data for belimumab. But what's interesting about this is they've used mixed data sources. For some analysis, they've had access to the patient-level data for anifrolumab. They have not used patient-level data for belimumab. So it's kind of a comparison using the best methods they could, but it means the methods are slightly different for the two products. So there's a few caveats to the interpretation of this. However, let's see what it said. So they looked at targeted outcomes of interest, so proportion of patients with a reduction in SLEDAI 2K of at least 4 points. And for people unfamiliar with that measure, it means that a manifestation like proteinuria or arthritis has to completely disappear, or points that are weighted slightly lower, like skin rash, thrombocytopenia, serology. You need more than one of them to disappear in order to get that much of a delta. So it's a clinically meaningful change in disease activity. And then they looked at the proportion of patients who achieved an SRI-4 response at week 52. The driver of SRI-4 is the same change in SLEDAI, plus some safety net captures that the patient doesn't worsen in the physician global assessment or BioLag scale. And the reason there is the SLEDAI doesn't actually capture everything that can happen in a lupus patient. And then it's the proportion of patients who had a flare, characterized by the BioLag method, the proportion of patients who tapered their steroid. And what that means is if you started on 10 milligram per day of prednisolone or more, did you reach 7.5 milligram or less by week 40? And did you maintain that all the way out to week 52? Okay, so they looked at the BLISS 52 and 76, which were the registration studies of belimumab IV, compared to TULIP-1 and TULIP-2, which were the registration phase 3 studies of anifrolumab IV. And the data, as reported, suggest a greater effect size of anifrolumab compared to belimumab. So what they've done is they've looked at the unadjusted data between the studies, and then done some sophisticated analysis that I don't think we need to go into to compare basically the effect size of the two compounds. And their interpretation was the effect size favored anifrolumab over belimumab for the 4-point reduction in SLEDAI and for SRI-4 response. And they did that in a couple of different ways and found the same thing both times. They didn't find favor of anifrolumab compared to belimumab for BILAG measured flares or for corticosteroid reduction. So there were no data in which belimumab was better or appeared to be better than anifrolumab. There were two important measures in which anifrolumab appeared to be better than belimumab. Now, what I hope this leads to is courage to do a head-to-head study, because I think that would really be super informative, and maybe these analyses with really quite persuasive deltas in this post-hoc analysis will give people courage to set up that kind of a study. What do you think, Ed?
Yeah, I agree. That was exactly what I mean, the things I thought looking at this. First, I was quite interested in the methods, how they've done it. And in the UK here, we have NICE who will try to make decisions about where new therapies fit. And they do use some of these methods to try and make indirect comparisons with all the limitations as you described them. So I was quite interested in that. They're essentially taking the anifrolumab data where we do have the patient level data and trying somehow to sort of adjust that to see how it would have performed, how the same drug would have performed in the trial population for belimumab. So yeah, I thought that was interesting. In terms of the limitations, the thing I really thought is that you can model the variables that are measured and reported in papers. But I sort of thought sometimes some of the reasons why these trials fail or succeed or get different results is stuff that's quite hard to see just by reading the protocol or just by reading the paper. There's a lot behind the scenes, isn't there, about the way outcome measures are used and adjudicated and medications are used and things that are quite hard to understand. And I think that's where the uncertainty lies for me. Yeah. Especially given, I suppose, the time that went on between these trials.
Well, that's right. There's a decade between these studies coming out, and background care has evolved over that time. We probably use more mycophenolate. We probably use less steroid, or I hope we do. Some of the patients in the anifrolumab trial would have had belimumab before, and maybe that means they failed belimumab. Does that? There's lots of variation. I've got one more comment though about another version of this study which could be done, which is that I'm aware that GSK actually makes the belimumab raw data available. We published a paper looking at the low disease activity in that. You have to use their portal, and it's rather complicated, but actually it is widely available. So there would be an opportunity to do patient level data side-by-side comparison, although it would be quite a lot of work. Maybe that's the next step that could be done without having to initiate the expense and time of a head-to-head study. But actually it could be taken one step further to side-by-side.
That's something we should try and do.
Maybe we should.
But I mean, you're right. It's generally the whole field, isn't it? It's going to start we've moved from a field where we were just struggling to get trials that showed whether these new medicines were actually helpful or not, that we're just starting to get into sort of being able to do that a bit more confidently. And as you start to get 2, 3, 4 medicines in lupus, we're going to get into all these questions that they've been struggling with in something like rheumatoid arthritis for a few years now, isn't it? It's about how you make comparisons, sequence of therapies, choosing which one for which patient. And
I look forward to that day, because that'll be a good problem to have compared to having nothing for the last 50 years. But yes, it's a whole new set of things we'll need to do in order to guide clinician decisions. But in your country and in mine, a taxpayer is paying for these medicines, so that money needs to be spent wisely too. So I think it's important. So the next paper is from Thomas Derner, and it's a study looking at the mechanisms of action of baricitinib. So as our audience knows, that's a JAK inhibitor that's approved for rheumatoid arthritis and a couple of other indications around the world. And it's had a successful phase 2 trial published a couple of years ago. And the sponsors have supported quite a bit of post-hoc analysis of clinical endpoints and also biomarkers, and this is one of those. So Ed, tell us about it.
Yeah, that's right. So yeah, as you say, the phase 2 is successful, but we don't have the full publication yet, but I don't think the phase 3 program has been, unfortunately.
No, I actually had the privilege of presenting those data at the EULAR meeting back in June. And unfortunately, one of the trials reached its primary endpoint, but none of the secondary endpoints. And the second trial didn't achieve the primary or any of the secondaries. And yeah, we await the full peer review publication to get that for sure. But yeah.
As always with these things, there's always, even when a trial's negative, there's always things within it that are interesting to try and
Absolutely.
work out. And I think this is definitely one of those medicines in that category where you really need to think a little bit about what's happening here in terms of the efficacy. So like you say, people will be familiar with JAK inhibitors quite widely, especially people who work outside lupus actually have been prescribing them more than I have for many years. But there is a good case for these drugs, for this class of therapies in lupus. So basically, baricitinib inhibits primarily JAK1 and 2, less so on JAK3 and TYK. And that means that the cytokines it targets, there are things like IL-6, there's a lot of these sort of T cell, NK cell cytokines like IL-2, IL-7, IL-21. But there's also type 1 and type 2 interferons that will signal through JAK1. And so and we all know that type 1 interferon is really important in lupus, as for anifrolumab that we saw earlier. So it makes a lot of sense to trial this. But it also means that there's then the question of is the efficacy that you get from baricitinib just due to, is it just another interferon blocking drug, or does it sort of do other things as well? And that's really what the analyses that Thomas Turner's been leading have been. So there was one paper which we reviewed a while back that was in Lupus Science and Medicine, which was a transcriptomic analysis on the phase 2 data. And this one's all about the serum cytokines. So they took the data from the phase 2 study where patients got placebo, baricitinib 2 milligrams, or baricitinib 4 milligrams. And in the lupus program, it's always been the 4 milligram dose that's shown the most consistent efficacy signals. And then they've analyzed the serum that was collected at baseline and at week 12, as well as on some healthy controls. And they've used this method that I've been looking at recently for some of my work, which is quite nice, called O-link, which is a sort of a multiplex method to measure lots of proteins in the serum that works with the antibodies are tagged with oligonucleotides so that it's read essentially like qPCR, which makes it very sensitive and accurate, and you can multiplex, so you get one of their target panels, you get sort of 92 different targets in one go with one small amount of serum. So it is a nice method. What they've done here is they've performed that in the healthy controls baseline and the 12-week serum, and they looked at the data in a few different ways. The first comparison is they just looked at all the SLE patients versus the healthy controls to see which of these cytokines and chemokines were altered compared to healthy in the lupus patients. And then they've compared the 0 to 12 paired results for the baricitinib, so the change, in other words, for baricitinib 4 milligrams compared to the placebos, or 2 milligrams compared to the placebos, or the 4 versus the 2. So it's essentially looking at how much do you get change you get from baseline, and how does that differ between those two different treatment groups. So as you'd expect at baseline, you just see everything's dysregulated. So as you'd expect in lupus, almost all the cytokines and chemokines are raised, and that goes across the board of different classes of these. You've got classic inflammatory cytokines like TNF, IL-6, IL-1. You've got some regulatory things like IL-10, that's up to, and of course there's all there's type 1 interferon is up, which means that what you see is lots of chemokines like CXCL9 and 10 that we know are induced by type 1 interferon. They're all up as well. So I think the baseline is what everyone would have expected to see. And then you get into the results that change over time. And I think the interesting thing here is that there are quite a large number of cytokines and chemokines that are changing over time. And some of those are those that are very directly influenced by JAK-STAT signaling, like IL-6, for example. So we would entirely expect that to have changed. But there are some others that change that actually aren't directly signal through JAK-STAT, like TNF, for example. So it's quite similar to what you see, to what was reported on the transcriptomic paper, which is that you don't just see the directly stimulated cytokines coming down. You get this whole network, this sort of cascade going through the immune system of other immune mediators changing. So my takeaway from this is that this drug probably does something quite useful to the lupus disease process. It's just, we just need to work out what that is clinically and who it's good for, and maybe how you measure it to really show what it's doing. Did you have any other thoughts about this one?
No, look, I think that's a good summary. I think it's always good to see data from patients with active lupus, the type of patients who are enrolled in a trial of active disease, refractory to standard of care as a rule, mostly taking steroids. So we can see that despite standard of care, people have active biology. Cytokines across the spectrum are up. So that's why they've got active disease. Their immune system is not suppressed by the drugs they're taking. And every time we see that, it's a reminder of the work we've got to do to make that better. Then I also agree that it's clear baricitinib hits its target in a lupus patient from a biological sense. So from a PK/PD point of view, pharmacokinetic, pharmacodynamic, the drug is absorbed, it hits its target, and cytokines are reduced. But what we've got, although it's not directly analysed in this paper because the phase 2 trial was positive, if the phase 2 trials further analysis confirms that they were negative, is it that the baseline cytokines were not up in the patients in that study, therefore the baricitinib had no work to do? Or were they up and then suppressed by baricitinib but somehow didn't relate to a measurement that we could capture in the setting of that trial? And as you know, Ed, because you're involved, we're involved in trying to set up new ways to more sensitively measure treatment response in lupus studies that might unveil things that we don't find with our current measures, and that work lies ahead. But yeah, I think it shows the drug is active. There's nothing about it just not working on the biology of a patient with lupus. It does. The challenge is connecting that change through to clinical benefit, and that's what we think we haven't seen overall in the context of the trials as they were executed. But I'm hopeful that the sponsor will allow access to this type of gene and protein expression data for those phase 3 studies that were negative. They have done that before because they had the belimumab program a few years ago, and they put a lot of data out, including RNA expression, microarray data into the public domain. That's been very helpful to the field. So we need to see negative data as well as positive to help us understand this.
Yeah. I mean, one thing you saw in terms of the clinical efficacy, one thing I keep noticing across the different baricitinib data sets is that there seem to be these effects on sort of joint pain that come up quite often, and sometimes even the effects on sort of pain and tenderness seem greater than the effects on swelling, which is a curious feature, but one that is interesting given the mechanism of action and probably potentially quite meaningful to patients, isn't it? So it's just an example of the kind of thing that we need to capture a bit better. And the other thing I suppose to say is that there are other inhibitors of the JAK-STAT pathway still in development on this. No,
that's right. I think we let's assume that the peer-reviewed results of the trial come out confirming what was in the abstract, that they're negative. I feel that's going to tell us something about the way that trials are done rather than about the JAK system in the biology of lupus, and the data like this support that conclusion, I think. Okay, well, shall we move on then to the next paper? So this is moving into the emerging therapies.
So this one's the study of it's 2 therapies, isn't it? So it's filgotinib or lanraplenib in moderate to severe cutaneous lupus, and they're both compared to placebo. Is that right?
Yeah, that's right. So I'm really glad to see this paper come out. It was published just recently by Vicky Worth in Rheumatology. And there's a lot of things I like about this study that I think we should learn from and copy. The first is it's a study in CLE, so cutaneous lupus patients, moderate to severe. Patients could have SLE as a diagnosis or not, but they had to have active cutaneous lupus. And that was measured with the CLASI activity measure, which is a increasingly well-validated measure for disease activity related to lupus in skin. Actually across mucocutaneous system, but the activity version doesn't include scarring and so on, and focuses on skin. So that's an interesting thing to do for a study like this, because skin changes we know now can be fast. We've seen that with interferon blocking programs, and also they're a lot easier to measure than some of the other things that we struggle to measure. You just count parts of the body affected by a rash and you've got a number, and you can measure a change in that number. So it's great to see proof of concept studies being done in cutaneous lupus. We don't yet know whether the biology of cutaneous lupus always translates to other manifestations of lupus, but we certainly don't know that it doesn't. And there's no reason actually in my mind to propose that it's definitely different to the rest of SLE. So here we are. The other thing I like about this study is that they have shown a bit of a way that maybe we need to do things in the future, because there's a problem in lupus trials around the world, which is for the first time in history, we've got lots of drugs being developed, and we're talking about several more of them in this forum. The ability to do high quality studies in patients with active disease is going to be constrained by the number of such patients available and centers that can do them, because you have to have placebo. So here we've got a more efficient way to do that study, put two compounds together against one placebo arm. So you can learn about each of the drugs individually versus placebo, and you can learn about the two drugs side by side. In this case, the company could make a choice to take the best one forward. You could even envisage a scenario where several companies would cooperate to do a study using a single placebo arm and just move the field forward in a more effective way. I think we're going to need to see changes like that. So that's my statement overall about the approach that was taken. So the compounds that we used here were two kinase inhibitors. So filgotinib is a JAK1 kinase inhibitor. I guess you might say it's similar to upadacitinib in terms of its targeting biology. And lanraplenib is a spleen tyrosine kinase inhibitor, or that's called a SYK inhibitor. I've always thought the idea of inhibiting SYK sounds good, because that must mean get well. So a JAK1 we know is downstream of multiple signaling pathways important in the pathogenesis of inflammation, including IL-10, IL-22, interferon gamma, IL-2, IL-4, IL-6, but also GM-CSF and erythropoietin. And spleen tyrosine kinase is downstream from the B cell receptor, so clearly involved in important activation of B cells. So this was a 3-arm study. Patients were randomized 2 to 2 to 1, with the smallest group being placebo, treated for 12 weeks, and the primary outcome measure was change in CLASI activity score at week 12. Patients were then re-randomized out of placebo onto active treatment and followed up to week 24. This was a negative study, so the primary outcome measure was not met for either compound, which was change in baseline CLASI activity score in week 12. But there's some important caveats to that conclusion. I mean, that is the conclusion of the study, but the numbers were small. There were 8 placebo patients who made it to week 12 for analysis, 16 SYK inhibitor patients, and 16 JAK1 inhibitor patients. So it's a very small study. And therefore, I think for a phase 2 study that's exploratory, it's not only permitted, but I would say encouraged to be exploratory in interpretation of other outcome measures and see whether there was anything there. I think the conclusion for lanraplenib, the SYK inhibitor, was that actually there wasn't. There wasn't really any sign of much going on. But for filgotinib, and probably unsurprisingly, there were signs in some of the secondary outcome measures of numerical advantage for skin disease for filgotinib treated patients compared to placebo. So this was one of those examples that should remind us that the phase 2 trial of belimumab was also negative. and our exploration of alternative ways to interpret the results led to the phase 3 trials, which led to registration of the drug. And the first phase 3 trial of anifrolumab was also negative against its primary outcome. So it's such a struggle to get drugs approved for lupus. I think we have to be rigorous in our science and strict in our interpretation and application of statistics. But at this early phase 2 stage, I believe we should be exploratory, curious scientists and look through the data to see what it's telling us. And in this case, I think it tells us that there's possibly an efficacy signal for JAK1 inhibition by filgotinib. Now, I don't know if there's enough of a signal to prompt a repeat study in a larger cohort to try to get a p-value. We'll go straight to a larger phase 3 program. I'm not aware of what the plans are for this compound. But anyway, that's my interpretation of these findings. What do you think, Ed?
Yeah, I mean, that's a really good point I think you made about the fact that they've chosen this quite interesting design at such an early stage. So we were just talking earlier about how I wish we could have some head-to-heads of the drugs we want to use, but actually this is a really good, and we also were talking about like which patient for which drug, what kind of biology does each therapy treat, and it's just a really good example, isn't it, of how you need to try and make those decisions early on. Rather than trying to do a really big study, just put in all the patients you can possibly find, and then later get in, if it's successful, get into trying to break that down into best responders or something like that. It makes a lot of sense to just try and make those decisions early like this. So
yeah.
So again, yes, I suppose it just makes you, I think the whole field of JAK inhibitors is still going to be an interesting one over the next few years.
No, I completely agree. There's a number of compounds that are currently in trials that haven't reported yet. There's another trial that has reported in abstract form, and we'll wait to see if the paper comes out for another kinase, TYK2. So yes, I definitely think the field is very far from finished, and look forward to more. Yeah. So now I'm going to turn the tables, Ed, and ask you to talk about this study, which has been long awaited. Actually, we knew the results by press release for this paper for more than a year, but the paper has at last come out, and that's the study of ustekinumab in a phase 3 trial for lupus. So what do you think, Ed?
Yeah, that's right. So unfortunately, again, this is a negative one. And like we were just saying, it's always important to think about, what and why. So again, just like with baricitinib, this is a drug that will be familiar to most rheumatologists. So ustekinumab, of course, used a lot in psoriasis, inhibitor of IL-12 and IL-23. And there's some rationale for exploring that in lupus as well. So there was a phase 2 study done. The phase 2 study did show some efficacy, although I think it has to be said there was some mixture amongst the different endpoints and time points in the phase 2 phase. And then this went into phase 3. And what we're actually looking at, like you say, we all heard about this from a press release because there was an interim efficacy analysis, so a kind of futility analysis done partway through, and it was at that point that it became clear that it wasn't going to be possible for the primary endpoint of the study to be met. So the study was stopped at an early phase, and that's it's that analysis that's been reported here. So just looking at what they actually did here, the most of the design is what you'd probably call fairly textbook in terms of how licensing trials are done for lupus therapies this time. And I was trying to look through it and think, well, was there anything here that I think should have been done differently, could have been done differently? And there wasn't anything hugely that stood out to me compared to other trials. So they took 516 patients. There was a 3-to-2 randomization to either ustekinumab or placebo. At 12 months was the primary endpoint, which was the SRI-4, like most other licensing studies. Some choose BICLA, but more choose SRI-4. And after the 12 weeks, there was a crossover where the placebo patients could go over onto ustekinumab. And the study actually ended at 2 years. And again, that was because of some of the phase 2 data that became a little bit more consistent in the latter parts of the study. So they included patients who had a SLEDAI of greater than 6 with a clinical SLEDAI of greater than 4. That had to be despite one standard therapy, either steroids or an immunosuppressant or antimalarial. Immunological markers, they had to have one or more out of ANA, double-stranded DNA, or Smith. And they had to have if the most patients obviously going in because of either skin disease or joint disease, so the SLEDAI rating had to be backed up by a CLASI of greater than 4 if it was for the skin, or a active joint count of greater than 4 if it was for the joints, and they also had to have a BILAG either A or 2Bs. So I think that's most of that relatively standard in terms of how those studies are designed. You made some are a little bit stricter on some of the serological markers, the disease activity markers at baseline. And then the outcome, SRI-4, again, quite standard. But looking at the efficacy in this study, of course, it's not the fully powered study. We have got an interim analysis, but it does look pretty flat for most of the endpoints, actually. So for the primary endpoint of SRI-4, it was actually numerically higher in placebo than it was in ustekinumab. So SRI-4 week 52, of those that were analysed, you got 43.9% on ustekinumab and 56% on placebo. And then in the paper, there are a few other analyses on things like CLASI response, joint count response, flare rates, and most of those also look pretty flat. There was one thing that kind of stood out, that was that the glucocorticoid tapers, so you could look at the proportion of patients who've got a successful glucocorticoid taper, and you could look at whether they could achieve that and an SRI-4. And those steroid-based endpoints, they did actually have they did show some benefit for ustekinumab, so nominally significant p-values of less than 0.05. So that was the only bit that really stood out as helpful. Safety, no concerns. And there was a little bit of biomarker data in there. And it's interesting to contrast it with the one we were talking about earlier, that so you'd expect ustekinumab to improve interferon gamma and P40 in serum, and it did, as expected. But what you didn't see was that what I was saying, did that then lead to a cascade of other improvements in other immune markers, and that didn't seem so clear in things like interferon alpha, IL-17F, IL-22. That you didn't really see that more broader effect. So my feeling here is this is a bit disappointing, but it probably just doesn't really work that well.
Yeah.
No, I don't know if you saw anything else more positive in this.
No, I didn't, but I think I've got a couple of other comments. I mean, one is that if memory serves correctly, ustekinumab was decided to be trialed in lupus because of a kind of big data approach, looking at various published biomarker studies and trying to refine what optimal unexplored therapeutic targets might be. And if memory serves correctly, ustekinumab came out of an analysis like that was done in the academic sector. And the phase 2 trial was positive on the primary endpoint, but the widest separation between active and placebo was on that primary endpoint day, which I think was week 24. And the separation between active and placebo was not as convincing on other time points. So that may have been just a strange glitch of some small number of patients across a small period of time. But the other thing about this paper, and you've pointed it out, the placebo SRI response is 56%. Which is higher than we've seen in any studies of lupus so far. So I hope that the authors will go deep into some post-hoc analysis and try to learn and teach the rest of us what happened in this study design, or in the patients, or was it the steroid taper or non-taper, to get such a high placebo response, 56%. I mean, if we saw a 56% response rate to SRI-4 for an active treatment arm, we'd say that's pretty good. Don't usually see as high as that, because placebo responses are more like 30 to 40. But here the placebo rate was higher than really, I think, any we've seen before of this type of design. And there must be a reason for it, and we need to know what it is so we don't do it again. And I think that's not going to be about the compound not working. That's going to be something about the patients or the execution or the design or the endpoint that yielded this this really hard to work with high placebo response. So I think we need to learn from that. But in the end, it's a negative phase 3 study of ustekinumab. It's not going to get approved for the treatment of lupus. And maybe that non-cascading cytokine effect is a factor in this. Having said that, baricitinib, which does induce kind of multi-pronged reduction in cytokines, hasn't been successful in phase 3 trials either. We always should remember that steroids are actually a targeted therapy. They bind directly to the glucocorticoid receptor, which has a very specific, although very broad, function. That also results in a broad cytokine suppression, and we know that it's effective. And the problem with steroids is not that they don't work; it's the adverse effects. So we're seeking to emulate those broad, fast effects with JAK inhibitors. We saw them in the baricitinib paper on the cytokines, but we haven't seen it clinically. Here, maybe we've got a narrower cytokine effect that was unable to yield a therapeutic effect. But I go back to my other point about the very challenging high placebo rate in this study, and that we need to learn from that. Now, this is not the introduction of a new therapy, but instead the tapering of therapy, standard therapy. And I think it's really, really important. We've seen some great papers recently from Matian et al. Tapering steroids, telling us what happens in those patients. Rate of flares are higher in patients who stop steroid when they have no disease activity, though that paper was stop steroids rather than taper steroids, and maybe we need to look again at a different approach. But the question of how long to treat patients with lupus nephritis for before stopping their immunosuppression is answered in guideline after guideline with very low level quality of evidence to recommend about 3 years or maybe a bit longer. But what do we really know? And here's a great study that's trying to help answer that question. So tell us about it, Ed.
Yeah, I really liked this one. I really liked what they tried to do and how they thought about the problem. Like you say, this is a problem. I'm about to go downstairs and do a lupus clinic after we finish recording today, and I can guarantee this question is going to come up, which is, yeah, I was ill with my lupus a couple of years ago. I'm well now. Can I stop these tablets? And I always say, I don't know. No one knows, but I wouldn't stop them if I were you, at least not yet. So how can we generate some evidence on that? So this is an academic-led study. It's French, multi-center study, and it's what I suppose you might call it's more about strategy than about does this intervention help or not. It's more about how should we use interventions and how do these things work over time, which is a kind of study I always quite enjoy reading. And so their idea was, if you take patients who've had lupus nephritis, they've had induction therapy, and we know there's a few good options now for induction therapy and some new combinations coming out. But so they've had their induction therapy, and now they've been put on maintenance therapy, which I think most people would use mycophenolate, but some patients are on azathioprine, and they've now been on maintenance therapy for somewhere between 2 and 3 years. And in that interval, they can then get enrolled into this study, and they were randomized 1-to-1 to either just continue that maintenance therapy for another 2 years to the primary endpoint, or to taper it and come off the maintenance therapy and see what would happen. These are all proliferative lupus nephritis patients, significant disease they'd had when they first received induction in the past. And it was a non-inferiority study. So in other words, I think if you saw non-inferiority, then you'd say you might as well come off therapy. So the primary endpoint was having a relapse of proliferative lupus nephritis at that 24 months endpoint. There was a secondary, which was having any kind of SLE flare, and they also looked at times to relapses. And I think, it didn't meet its non-inferiority endpoint. So the hypothesis was they would be non-inferior, and that was not supported because the discontinuation arm had a relapse rate of just over double as double as many relapses as in the patients who'd continued immunosuppression. So 12.5 relapses at 12.5% of the patients who continued maintenance therapy relapsed at 24 months, compared to 27.3% of the patients who had discontinued. And it was quite a similar result for the non-renal flares as well. The other thing that they showed that actually I thought that's quite useful is of course, they looked at safety of these two arms and found no difference at all in the safety. And I thought, in my conversations with patients, that's quite a useful fact, isn't it?
Yeah.
If you come off this therapy, you're twice as likely to have a relapse of your lupus nephritis. But if you stay on this therapy, there's no problem with that, actually, as far as we can tell from this evidence in terms of the safety. I mean, so this study is 40 patients versus 44 patients. It's not massive, but that would fit with what I think clinically, which is the safest thing to do is leave things as they are. There is, of course, now an unanswered question, because I think when you, like you say, in guidelines, they say something like high risk of relapse after about 3 years, probably a bit less after 5 years. It's somewhere between them is where you might consider it. So I think we can say that I wouldn't stop therapy before 3 years, but I don't now know what I should do with someone who's been on therapy for 5 years and is in remission, or 6 or 7. So there are still unanswered questions, but I liked this one. I thought it was helpful.
Yeah, I think it's super helpful in terms of giving us reason to persuade, I think with, strong evidence and a big delta for patients to not stop therapy early. Yeah, the size of the effect is large. It's double. And not only is it double, it's not 1% doubling to 2%. It's 13% doubling to 27%. So 27% is almost 1 in 3 would have a proliferative nephritis relapse. Not just any old relapse, but a relapse of proliferative GN within 2 years, which is not long. So the benefit of staying on that treatment for 2 years with no delta in safety is very clear. And I think this is helpful. But I agree with you. What do we do at year 4 or 5 now? We've got a same question 2 years further down the road. And yeah, we just don't know. I mean, maybe patients need to transition not onto nothing, but onto maybe a disease-modifying biologic of some kind, targeting B cells or targeting innate immunity, and we just don't know yet. But what this also affords is a potential study design for such a study, because we know now what the relapse rate is of lupus nephritis when immunosuppression is stopped. And unfortunately, it's high, but fortunately, it's high enough that you could measure an effect of an intervention in a pretty small and efficient study design. So I just wonder whether that might be the sort of thing that we try to do in the future, is take this study design and randomize people to stopping or transitioning to another therapy. On the other hand, sorry, I'm talking a lot, the mycophenolate is pretty cheap and had good safety. So why would you change them onto something expensive? Yeah, it's tricky.
The other thing I just thought, I just remembered reading this, was that, of course, with lupus nephritis studies, you've always got to look at ancestry. So this was a European study, so about 2/3 of the patients were white European ancestry, which probably means it was relatively conservative about the relapse rate, I would imagine. If you go out to different ancestral groups, things will be worse.
Yes, I agree with that. Yeah. Well, food for thought, but I think as you go to your clinic in a couple of minutes' time, you'll know what to say to that patient who asks you.
So that's our last paper of this month's podcast. So thanks for joining me, Eric. It's been great to hear your views, your insights into all these topics and papers, and I hope you'll be able to join us again for another one of these soon. And thanks for everyone for listening. Hope these discussions have given you a good overview of the current lupus literature and some useful takeaway messages to help in the practice. So as always, on the Lupus Forum, you can get full slide summaries of all these papers in greater detail. You can find on lupus-forum.com, and you can register to be notified when more of these materials come out, and you can download those PowerPoint presentations to use in your own teaching and your journal clubs. And you can also find us on Lupus Forum, all one word, on Twitter and on LinkedIn. So thanks again, and see you again next time.
Bye-bye.